develop disease, expanding beyond breast cancer, disease-related groups that cut across the MedStar institutions to have our clinical research being available throughout the network. We've started to expand bone marrow transplant with the relationship with Hackensack University up in New Jersey to set up a bone marrow transplant program, which has allowed us to focus on hematologic malignancies in this region in a way that we haven't in the past. Like many centers, we've increased our focus on tumor immunology and immunotherapy using new drugs that can restore the activity of the immune system to recognize cancers. And it's been a major interest of mine and Dr. Muir, the directors, and so I'm delighted to see that that's actually an area that we can make progress in. It's an area of expansion. And we're also been focusing on not just bench to bedside research where we take something from the lab to the clinic, but where we actually take things from the clinic and bring it back to the lab to try to figure out how to use it better, what we call bedside to bench or reverse translational research. And that's because there are now a lot of drugs that work in cancer that are approved, but we have to figure out how to use them best, how to give them to which patients, how to use them in combination, what stages of disease to use them in. And one of the areas that we've focused on, which sort of goes towards personalized medicine in this sort of interaction between bench and bedside and back, is the development of conditional reprogrammed cells, which is what Dick has done, which really, and he'll tell you a lot about it, but it gives us a chance to grow tumors in a way that was not possible before from all different types of patients, and use that to try to identify new treatments for rare tumors for which there were no cell lines to test drugs against, and to study cancer biology, to study mechanisms of resistance, what changes when a tumor becomes resistant to a particular drug, or study tumor heterogeneity. If you look at different neighborhoods within the cancer, how are they different and why are they different, and what happens when you target particular neighborhoods, what actually grows out, and try to model that in the laboratory and help us then treat patients. And so this is really an exciting development for cancer as well as for potentially regenerative medicine. This is what Dick has discovered and what has been known around the country as the Georgetown method for developing cell lines in growing tissues. And I'm delighted that you're all coming here to hear me about this. Thanks.
Thanks, Mike.
Thank you.
So we are going to hear now from Dr. Richard Schlegel, who is going to describe in much more detail the conditionally reprogrammed cell line work that he's involved with. It's very exciting and very innovative work. So I will turn it over to Dick.
And let me just quickly say that, like, for all of the speakers, you have a complete bio and contact information in your packet. And I encourage you to read it.
And they do record sessions, so
Okay.
plop the tape down.
Okay, super.
Will the slides be available on the website?
We can get copies. Yeah.
Yes.
Sure. Yeah, do that post. You could do it for me, sure.
Great.
Okay, super. First, Michael, thank you very much for coming and giving an introduction to the Lombardi. Michael didn't mention the fact that we were lucky to recruit him from Harvard recently, about a year and a half ago. He's a premier researcher in the area of melanomas, and he heads a section on that, and has interactions with the different groups of MedStar in melanoma research. And when he was at Harvard, he had a program project, which is multiple investigators all focused on these things, and he was the leader of that, and continues to have a major role actually in developing the approaches to treating melanoma. Before I begin, I'd like to introduce a couple people that you will meet today, either on a film or in real. Sherry, you're going to meet in both formats. Sherry Wallington is here. She's an investigator, a professor here at Georgetown. She's been here for 4 years?
Since 2009.
2009, okay, all right. Anyway, we got Sherry, we enticed her to come down from Harvard, and she is going to talk about the work that she's doing on human papillomaviruses and the vaccine, and really how to make it available to people, major problems with that. Anna Regal is a professor in ecology here. You'll meet her in the real, I think in her laboratory, and she's really she's been studying breast cancer in animal models, mainly in mice and in humans, and she has done some unique things with being able to study these cells, developing tumors in animals, taking them into tissue culture and taking them back, and in cases using the conditional reprogramming, but has done some spectacular work in that area of breast cancer. And Heywan Park is, I always say, the center of the center. We have a Center for Cell Reprogramming. She's the Director of Business Operations, which means almost everything, to try and keep the center running and have interactions with foundations and with companies and with outside investigators to facilitate the development of this technology. Before I talk about conditional reprogramming, we have a movie that I thought part of it was made by the Georgetown University Medical Center. Sherry's going to be in that film, I think, starting it off, sort of. But it's going to focus on human papillomaviruses and cell reprogramming, and there's some neurobiology thrown in there, too. But anyway, I think, if you don't mind, I'd like to kick that off, just sort of a 4 to 5 minute introduction. I'm not sure if we need to turn out that light, but... let's see here, if we can move this down here. And...
No sleeping allowed, by the way.
That's right. I'm just trying to see my switch here. Will that take me to where I want to go? No.
Just up in the right corner, I think if you, the little open box.
This box, you think?
There you go. Close enough.
If you could play, scroll down.
Page down.
I don't see the...
If you click play, maybe it'll give you a little
Just
box.
click the middle of the
Just
screen.
click that arrow.
just click there?
Yeah.
Yeah.
There you go,
Okay.
now on the right hand side. You can
All right. Now I just need a full page, though.
No, go to
On
the
the
right
right-hand
corner.
side.
No, up. To
Oh,
the-
up there?
No, in the picture.
Oh, in the picture.
Wait,
Go there.
Bottom
See,
right,
Next to
bottom
YouTube.
right.
Next to the
Oh,
word YouTube.
okay,
Click on
gotcha.
that. Yeah, that.
Okay.
There you go.
Now, we're going to have low sound, huh? Oh, that's not working. We may have to stop this a second, otherwise this won't make too much sense.
There, see the speaker in the corner?
There you go, it's right there.
Well, these speakers, we can hear it,
Ah.
unfortunately, through here, but not through the main speakers.
Okay.
Yeah, they're just coming through the computer system right now.
You guys can cure cancer, but.
That's right. Forget about the graphics, right?
AV is tough.
We'll come back to that again. Dan will be here in a minute. Anyway, if we have difficulty starting it up, I think what I'll do is explain what we're trying to do with conditional cell reprogramming. It's a method that allows us to grow human cells. Hi, Dan. We're trying to get this to play out to the speakers so that we can get people to hear.
Okay.
And is this...
It might be able to. Yeah.
It's unplugged? All right.
Try it.
Okay. Try this again.
next to YouTube.
Oh, you can
See,
hear it.
Bottom right.
Oops.
I was diagnosed to a certain
Click
cancer.
allow.
Okay, all right.
If they had had a vaccine back then, maybe I would not have gotten cervical cancer.
I experienced a stroke. Life changed, and I couldn't do for myself what I would normally do. And thus began the journey of rehabilitation.
Before
module in our workshop on HPV and HPV vaccine. The District of Columbia, it has one of the highest rates of cervical cancer. We are conducting a randomized controlled trial that seeks to educate mothers about HPVs whose daughters have yet to be vaccinated.
I really learned a lot because I didn't even know anything about HPV.
What we hope to find is that mothers will have increased knowledge about HPV and higher uptake of the HPV vaccine for their daughters. Becoming aware of HPV.
I'm very grateful now that they do have a vaccine to prevent my granddaughter from getting cervical cancer.
Dr. Richard Schlegel in his lab here at Georgetown is responsible for inventing the technology for one of the vaccines, Gardasil.
It's a dream of a scientist to be able to discover something in a laboratory that might not only be interesting to other scientists, but have an impact on the healthcare in the country, or in this case, in the world. 2 days, I mean, look at the size. But in a whole nother avenue, we've developed a technique for growing tumor cells in tissue culture now very rapidly. The technique that we have allows us to take a biopsy of the tumor and take a biopsy of the normal tissue and to grow both of those up from that patient, and then to find drugs that kill the tumor cell and not the normal cells. So it's an exciting time.
I hear a story like yours where it happened after the stroke. That tells there are about 800,000 people a year in the United States who have a stroke. About half of them are left with some sort of problem with their arm or leg weakness. And what we're trying to do is improve their outcomes by improving the treatment. This study is the largest phase 3 randomized controlled trial in rehabilitation medicine. So over this, it should influence the kind of treatment people get in the United States in the future. And we hope around the world. Pretty good. Pretty good.
This research study is important. It helps stroke patients improve the quality of their life.
Healthy child.
This is a healthy child.
Children seem to recover from stroke much better and in a very different way than adults do. We're one of the only places that has tried to use insights from what we know to be abilities in children to understand how to get recovery to improve. I moved to Georgetown in order to do the kind of research that I'm doing here.
We're going to get started now.
Our biggest aspiration is to enable people to really recover from big injuries to the brain.
That's the real goal of research, is making sure that what we discover in the lab is actually applicable and is available to those individuals who need it most.
Flip that on again. Okay, so that sort of gave you a little bit of a background, sort of a glitzy background. Let me see, I want to shut this down. And so, let's see. I'm going to give you the introduction to the technique that we're using that a couple years ago when we published it, there were some editorials published on a technique. They called it the Georgetown method. We don't call it that. We call it conditional cell reprogramming. And I think it's going to have a major impact, not just in applications in biology and medicine, mainly in medicine, to testing for tumor sensitivity, but for regenerative medicine. And that's what I'd like to emphasize and explain what the technology is. And some of you may know that it's not very easy to grow some human cells in tissue culture. Let's see if I can get this to work. These represent some cells taken from a patient, and they're growing in a plastic dish. And as you passage them a few times, especially cells like prostate and breast, they will eventually undergo senescence. They stop growing, and they sit there. This is called the Hayflick limit. I won't go into the aspects of this, but it's a very complex process where the cells decide to sit there and they're alive, but they refuse to divide. You can trick these cells into becoming a permanent cell line. We have a lot of cell lines that are available right now for scientists to study, but these are either derived from rare events that occur here in a tumor, that the tumor cells acquire the ability to keep growing, or we can actually add oncogenes to them, or either viral or cellular, and convert these to this type of continuously growing cell population. HeLa is a perfect example of this. It's an HPV-induced tumor, and that grows forever in tissue culture. It's not a good model for normal cells, obviously, because a lot of the normal regulation of growth is completely perturbed. So it would be good if we were able to grow normal cells for prolonged periods in tissue culture, as well as tumor cells with an increased efficiency. So this is basically the technology. I don't think I skipped a slide here. What we do is we take, in pathology, we get material that comes in from the surgical suite. It comes to my department, and we dissect it. Normally what we do is we fix it in formaldehyde, or we freeze it, and we study its properties, and we send a diagnosis back to the clinician. What we're doing now is we take that tissue, or biopsies of patients, and we essentially break it into pieces, into cells, and put it in tissue culture. And what we found with this technology there are two components that are critical for it. There are feeder cells. These are like stromal cells. These are like fibroblasts that are on the plate. And there's a chemical called a ROCK inhibitor. It stands for Rho kinase inhibitor. But the bottom line is these two components, cells plus this chemical, allow normal tissues to grow forever in vitro. So these are prostate cells, and these little arrows here point to some of the feeder cells around the edges, and I'll show a better slide in a second. So we can go prostate, breast, and trachea, and these cells will continue to grow forever. The advantage of that is now we can come back and compare tumors from those patients if they have a tumor, and look for differences and try and target the specific difference that is in that particular patient. And this just shows you what they look like when you start a culture. These are the feeder cells over here, and here are some epithelial cells. These may be prostate, they could be breast as well. Almost all epithelial cells look the same. And I should mention that in humans, 90% of cancers are due to epithelial cell tumors. About 10% are from mesenchymal cells. 90% are from the epithelium of the breast, the colon, the lung, the prostate, and other sites. But anyway, they all look the same when they're growing here. And this shows you when you put them on our conditions, these feeder cells plus this inhibitor, that they grow forever. We've had prostate and breast growing for 2 years, normal cells, and they retain their normal biology. Their chromosomes don't get messed up, and these cells, both prostate and mammary, I show, continue to grow. If you take away either the feeders or the ROCK inhibitor, they stop growing. So this is why we call it conditional reprogramming. These cells are reprogrammed to grow, but if you take away those conditions, then they stop growing. And that's an important aspect that I'll mention for regenerative medicine in a couple of slides. This just simply shows this. I won't go into details on this. These list many of the adult stem cell factors that are induced under our conditions. And so there are a lot of membrane-associated proteins, there are a lot of nuclear proteins that you normally see in stem cells that our conditions induce and maintain as the cells continue to grow. And when you take them away, I won't show that here, when you take them away, then all of these factors drop out and the cell reverts to a differentiated state. And this will give you an idea of how that works. If you take cells, these happen to be skin cells now growing in tissue culture, and these happen to be lung cells derived from the trachea and the bronchi. And you really, morphologically, you can't tell them apart. Again, these are the feeder cells over here. But when you take these cells and you put them at what we call an air-liquid interface, so this is a membrane here, this membrane. On top of that, we put the epithelial cells, and underneath that, we actually have medium. And what happens is the medium feeds the cells from the bottom, but they see air from the top. So that's sort of what our skin sees. It's being fed from the bottom, it sees air on the top. The lung is the same thing. It's being fed from the bottom, and obviously you're inhaling air, and that's on the top. And in all cases, skin cells, despite the fact that they look like these in tissue culture, forms a well-differentiated skin. You've got a nice squamous epithelium, all the different layers, and even a stratified, cornified surface here. And the lung cells form ciliated lung cells. And this is an important feature. We've reverted the cells to a state that's an intermediate state of differentiation. They will go back to their differentiated state upon removal of our conditions. This is very different than embryonic stem cells or induced pluripotent stem cells, where you can't get them to differentiate unless you spend a lot of time and adding different factors to get them to differentiate in a certain direction. But that's not the case for these. These do this automatically. And to give an example of that, and this is sort of exciting for us, if you take skin cells and you grow them under existing conditions right now, not our conditions, and you grow them in a plate, you can transfer them to an immunodeficient mouse and get skin to form. And this is the sort of skin you can see. I may have to hit this light again. Thanks. So this is the skin over here, sort of like I showed you on that air-liquid interface, very well differentiated. But what you don't realize here is this doesn't have a lot of the other properties of skin that cells grown under our conditions do. We have in vaginations the development of hair follicles and adnexal structures like sweat glands and sebaceous glands that you don't get in this particular preparation over here. So under the conditional reprogramming, the cells that we grow up, we're retaining a lot of the different stem-like states in different compartments of the skin that you don't retain under these conditions over here. So I think this is an important feature, is we're retaining a lot of heterogeneity from the primary tissue that we've biopsied, and it will go back to that state essentially by itself. This is coming back to the lung. I showed the picture of those ciliated cells in the lung. If you do that almost in 3D, these represent the top surface now would be the air, where the air is seeing the cells, and the bottom is where they're being fed the medium. And what you see, all these white spikes over here, these are stained with an antibody that recognizes the cilia on the epithelial cells. So these are what beat and move the mucus from the bottom of our lungs up to the top so we can swallow it and get anything out of us that's in our lung. So all of these are ciliated cells. But these green things are actually mucus-forming cells. So they're making the mucus to trap the organisms and debris that's in the lung, and then that gets swept away by these ciliated cells to remove it from the lung. So these cells came from CRCs, so just to show you that when you put them into a different condition, they revert to their well-differentiated state, and they retain different phenotypes, both ciliated as well as mucus-forming cells. If rather than putting those cells on an air-liquid interface, you can also fool them another way that they're in the right environment, and that is putting them in matrigel. This substance is something like a basement membrane, like the bottom, and with nothing in the middle. So now what has happened is these cells, it almost looks like a mini trachea or a mini bronchus. All of these are epithelial cells, and on the inside, these are what we call polarized. Only on the inside you see the ciliated cells all along here. And I could show you a movie of this, but I'm going to show you on the next slide is a higher magnification of this area over here in time lapse, just to show you that they don't just look normal, but they actually act normal. And I think if I have to go to this, okay. Oh, it looks like we don't have QuickTime on here, huh? QuickTime not available. Oh, bummer. Okay, so what happens is all of these cilia beat, and they're all synchronized. So, and they're all beating in the same direction, so that the mucus that's in the center of it is sort of swirling around, and all of these cilia are beating in the same direction. So these cells communicate from one to another. Here's a cell here and over here, and they're telling one another beat in this particular direction. So it's a very well differentiated system. You can also get other epithelial cells to terminally differentiate. These represent prostate cells that were grown just like on a plate like I've shown you, and if you put them into a mouse, they actually form, an immunodeficient mouse, they form prostate glands, they secrete prostatic secretions just like you would see in a real prostate gland. So you can trick these cells to go back to their differentiated state very easily by removing the feeder cells, the ROCK inhibitor, and putting them in an appropriate 3D environment. So I'll come back to that, but that has a lot of implications for regenerative medicine in terms of, say, babies that have oxygen toxicity to the lungs, and they have a lot of damage to the epithelial cells. If we were able to grow those out from that patient and put them back onto the epithelium, then the prediction would be that we'd be able to replace that with normal cells. And the same is true for other situations where we actually have studies ongoing with trying to grow pancreatic beta cells so that we can grow up the cells that are making insulin. And there was a recent publication in Science that came from Harvard on using iPS cells to do that, but we can do that apparently much easier with our system. So what I'd like to show here is I've shown you what normal cells can do, and these are tumor cells from the same patient, a prostate cancer patient. And they make tumors in animals. The normal cells don't make any tumors over here, and the tumor cells make tumors. So the technology, the way we envision it, is we're going to use both of these cell types then, use these as the control for screening for drugs that will kill these cells, but not these cells. But perhaps even more important, being able to dissect out the genetic differences that are here that aren't here. I mean, all of us have unique genotypes and variations in the proteins that we make, but what we want to know is really the changes that occur here that don't occur in the normal cells of that patient. And this is an example of looking at a karyotype. In many cases, there aren't a lot, at least in prostate. This is a primary prostate tumor. And I think there is one cancer line out there that came from a primary prostate. All of the others are from metastatic sites, a very, very different behavior to them. But these are the normal cells from the patient, so it's got normal chromosomes, 2 of each of these, and XY obviously because it's a male. And the carcinoma is fairly normal, but actually has 3 copies of chromosome 13. And it's got some other genetic mutations that we think are really interesting to pursue. But we would not be able to do studies like this using our standard pathology techniques because we don't normally grow live cells that would allow us to do karyotyping like this. We could do genetic analysis, but as I'll show you in a little while, the karyotypes can be very, very important. This is a study that we did in collaboration. Seema Agarwal is now at Georgetown, but at the time she was in David Rim's lab at Yale. And she did this study over here, and we did this study down here, showing that if you take a pancreatic cancer, you can grow it in tissue culture also. And in 3 of the 4 cases, we had mutations in a gene that's called KRAS. And about 80% of the time, patients with pancreatic cancers have a mutation in this gene. And in 3 of the 4 cases that we grew up, we retained that genetic mutation. So that will allow us now to explore ways to study these tumor cells and find ways to inhibit their tumorigenicity. This is just a simple, I won't go into details. You can see that there are 2 components. A lot of tumors are very complicated. They're just not, these are the tumor cells over here, the epithelial cells, okay? And some over here, but and they're around. This is a nerve right here, and they're close to a nerve. But there are a lot of other fibroblast cells, mesenchymal cells here that aren't present in our cultures. and the genotype or the expression profile reflects that. So I think there's a lot of potential for using this system to identify at least the epithelial specific changes that are important for forming these tumors. These stromal effects may be very important, and there are probably ways to address that with this system as well. But it's obviously a very complicated story. We've been able to grow other types of tumors. I mentioned that 90% of human cancers are what we call carcinomas, or epithelial tumors. There are some that are unusual types. This is a neuroendocrine one, that these cells express some proteins in them, essentially, that are characteristic of neural tissues. And this happens to be a very rare cervical cancer. We got it because our lab studies cervical cancer. But it was a woman who was 25 years old, and the year previous had a normal pap smear, and at 25 she had another pap smear, and it was abnormal. And at the time of workup, she already had metastases to the lungs and liver, and within 8 months of diagnosis, she had died of the disease. This tumor, the neuroendocrine cervical cancers, are amongst the most malignant of all diseases. They're only about 5% of cervical cancers. They're hard to pick up on pap smears, and there's no known therapy. So what we've been able to do is to establish for the first time a culture of these, so that we can now start to probe what are the pathways are activated, what drugs might be effective against it. Since it's rare and we don't have a lot to work with, there aren't any real clinical trials being done on this, that it's so rare. But anyway, these are some of the markers that we see expressed. It makes tumors in animals. But I think the important thing is, having this line, we can now work with other groups. We have a collaboration with the NIH. There's a program called NCATS up there for advanced technologies. And they actually have a robotics, I don't know if you know about these systems, a robotics system where they can grow many different types of cells, but they can screen them against anywhere from 3,000 to 5,000 to 6,000 different drugs. All of the FDA approved drugs, but also many experimental drugs. And so we're working with Jim Inglesi's group up there to identify drugs that would be effective against this rare tumor. And it's not just this rare tumor, we have other rare tumors that are very difficult to treat and with no known therapies, like of the salivary gland. And we're growing up cultures from those to take the same approaches to identify drugs. And if you ever get a chance to see that facility at NIH, it's fantastic. They've got these huge yellow robots that are moving things from incubators, and they're feeding the cells, and they're testing them for their growth properties. It's fantastic. It's Star Wars. Another thing that we can do, and this is that tumor, for example, is what's called sky analysis. It really stands, doesn't matter what it stands for. It's a way to color chromosomes. I won't bother with it. But K is for karyotype, and S is for essentially for spectral. But it's a way to make probes that color each chromosome a different color. And what you can do with this technique, which you really can't do with the straightforward sequencing techniques that are used commonly right now, is to look for translocations. And one of the things that occurs in cancers is chromosomes break and they reassemble with parts of the chromosomes that shouldn't be there. So one part of a different chromosome will translocate to another chromosome. And you can see normally a chromosome should be one color. So here's a red one down here, okay? But in some cases you can see over here, here's a red one that's got yellow on the end of it. That means one of these, in fact, there's a translocation you can see here. This is what they call a reciprocal translocation. The yellow chromosome donated part of itself to the red, and the red gave part of itself to the yellow. And this represents, these can be very significant in terms of turning on cancer genes and altering the biology of these tumor cells. And I won't go into the details, but the tumor that I just described, this cervical cancer that's very aggressive, it has HPV in it. And unlike all other HPV cancers, it doesn't care if HPV is there or not anymore. What's happened in this particular case is the HPV has integrated next to a cell oncogene called MYC. and it's actually that gene that is driving the tumor formation. So this is a very rare tumor and different in biology as well as the HPV requirements for tumor formation. This, by the way, is something else we can do. It's called FISH analysis for fluorescence in situ hybridization. But anyway, what we can do is we can localize the genes. Let's see who's who. Mick is green and red is HPV. Red is the HPV over here, and it's integrated right next to this oncogene MYC. And actually there's a translocation here I was showing you before in some chromosomes. So it's actually duplicated itself. And so we have the HPV driving an oncogene in this particular case. And the as I said before, this is very different than normal cervical cancers. So I'd like to end with the clinical application that we had here at Georgetown. And again, this stems from our work on HPV. It's a 23-year-old male, and I don't know if you know this syndrome called recurrent respiratory papillomatosis. Newborns, if they are delivered via normal birth through the vaginal canal, if they aspirate anything from the mother going through the canal, and if she has an HPV infection, she can end up with laryngeal infections. And they are very aggressive, rapidly growing tumors. This patient had 350 surgeries to keep his airway patent. If you don't surgically intervene, you asphyxiate essentially. In about 1%, this is a bad disease to begin with, and we're currently studying that actually. It can get worse. It can actually spread into the trachea and the bronchi and then into the lungs, and it's a fatal disease at that point. This patient had many different therapies. None of them worked, and it was increasingly aggressive. And essentially, at the last operation, the pulmonary surgeon said they couldn't resect any more lung because there wouldn't be enough function left to survive. So we got a piece of that, and we used our conditional reprogramming to generate a line. And I won't go into details, but just the important thing is, within 36 hours, we had normal and tumor cells growing out. And with 8 days, we were able to complete a very simple screen for chemosensitivity. And I mean really simple because, first of all, there's no known treatment for this. So we just went out and we found from the internet any drugs that might work against cervical cancer. And so we had 4 or 5 drugs that were reasonable for that. And we screened those. And I won't go into this because we're almost out of time for this section. But there was a mutation in the papillomavirus that made it even worse. It had twice the number of oncogenes that it should have. But this represents, I think, the strength of the method. These are normal cells in blue, and these are tumor cells. And this is a drug that is used a lot to treat this lesion, and it had no effect on either cell type. This is important because this patient was going to go back to the NIH and be treated with a different formulation of cidofovir because they thought it might work. But we showed that at extremely high concentrations, it didn't bother the tumor at all. There was another drug that we know works very well on cervical cancers. In fact, we have some trials ongoing on that I will describe a little bit later on, very briefly. It didn't really have any difference between normal and tumor. And this is a drug that was described, at least in vitro, that worked on the tumor cells and was less effective against the normal cells. This drug is clinically approved to treat a cancer, a skin lymphoma, and the good thing about that allowed us to use it clinically on the patient. And the patient was treated a year's therapy. Within 3 months, there was a 30% regression, and it stayed like that. The patient has been out 3 years now since this procedure, and this is still sitting here. We don't know what's happened to those cells, but there's still a lesion, but it's not growing anymore. So that's a major breakthrough for RRP because there were no known therapies for it. And I think as time goes on, this was just published a couple weeks ago in Science. Jeff Engelman, who we talk to a lot and is going to come give a talk to our center in early January, published a very nice paper in Science showing that our technique is able to isolate tumors from patients with a very specific way. It's essentially CT-guided needle biopsies. He goes in and takes a needle biopsy and he grows it in tissue culture. And he shows that the genetic changes in the tissue culture cells are the same as the one that he has, that the patient has, and that you can make certain predictions about the response of these tumor cells in vitro, and they seem to reflect what goes on in the patient. So I think that's going to be very important, and I think it'll be, if that gets validated with more cases, will have a major impact on how we start to treat metastatic diseases. We can take small biopsies and grow them up and find out what are they resistant to and what are they sensitive to. And based upon this, and so this is sort of an ad for Georgetown here, a company was spun off called Propagenics. We were really fortunate. I gave a talk in Virginia where the ATCC is, the American Type Culture Collection. They maintain all the cell cultures for the country. And the president of that has become the president for Propagenics, which is a spin-off biotech company, to really be a platform company for developing the technology for regenerative medicine as well as chemosensitivity and chemoresistance studies. So we're really enthusiastic about this. They just got started in April, so it's a neophyte, but with a lot of potential. They already have potential interactions with companies that want to start testing this for chemosensitivity. So this is the last slide, and it's an advertisement for pathology. Normally in pathology departments, we're used to fixing things in formaldehyde or freezing them. But in the future, not in the future, we're currently doing this right now, and I'll show you the laboratory soon. Well, we can take surgical specimens coming in from the surgical suite, needle biopsies of tumors, aspirates, blood and urine. We're really excited about blood because there's a lot of emphasis on circulating tumor cells and how they might be useful for detecting and characterizing cancers in patients. And we think we have a way to grow those, and we're working hard on that. But by using conditional reprogramming, we can generate a biobank of cells that really gives us an inexhaustible supply of tumor cells for analysis. And there are a lot of nice correlations we can see. For example, in molecular diagnostics, these already exist in the pathology department. We already do a lot of DNA analysis, proteomics, metabolomics, and things. We can now correlate with live cell biology and get a lot more information about the genetics of what we detect on dead tissues, essentially, or extracted tissues. So I'm going to stop there. I can take some questions here, or we can wait to the very end, but
in order to keep us on schedule, maybe a couple of quick questions. We're going to be splitting up into two groups and going to Dick's lab and going to Dr. Regal's lab, so you also have chances in those smaller groups to ask Dick questions as well, because we're going to switch. Everybody's going to get to do the same thing.
Okay, so maybe we'll take two questions then. There was one here.
So I wanted to go back to the development of Gardasil and your role in that. Had you anticipated the strong vilification that came along with FDA approval in advance?
You know what? We're going to cover that with Dr. Wallington.
Okay, right. But the answer was no.
Okay. Thank you.
Yeah, right.
Look forward to it.
Yep.
Yeah, I had a question about going back to the chromosomes. Why, what triggers them to break off, and reattach to other?
That genetics, it's a very complicated process. I don't think there's one factor involved, but during the division process, there seems to be a lot of instability in these chromosomes, and they're able to break and to reassemble, and sometimes they choose the wrong chromosome to reassemble with, essentially.
So it's like a natural process, I guess you would say?
No, it's not a natural. It's an abnormal process. You don't ever see those rearrangements in normal human cells, actually. Yep.
I'm just curious, how long do you think before this would become standard operating procedure really everywhere? And, insurance companies getting on board to actually cover this sort of thing?
I think it's Jeff Engelman's study is really the beginning of the validation phase. when that gets validated on more tumors and people confirm that you can make predictions from these tumor cells, then I think it'll be more widely applicable. And there's already a company being formed to test that out and validate that system. So it's another Boston group, actually. So, okay. Our last one? All right.
Yeah.
So with more common types of cancer, are you seeing this technique able to recommend different, maybe unrealized treatment approaches that might not have been tried with a common type of cancer in the past?
Yeah, I mean, that's the good thing about it. We can
The
screen.
idea, right, is that you could
Right.
find it better.
Or a combination, right? Not just a single agent. Combination agents might even be the best way to go. But we've come up in cervical cancer, that one compound I said that worked well, DHA, is actually an anti-malarial with very strong anti-cancer activities, and it doesn't kill the normal cells. So there are going to be a lot of unexpected drugs that pop up in these screens that, why would you have tried that?
I mean, it kind of redefines cancer.
Yeah, I mean, it's what we do in pathology now, in clinical pathology. When a patient has a throat infection, you take a swab and you plate them out, and you put different antibiotics, and you look for the one that works, right? And we'll just be using a much broader screen, essentially, to identify new drugs. But one of the outgrowths of our interest in cervical cancer was trying to find ways that are, what would I say, cost effective for developing countries to treat cervical dysplasia. And we made it using our tissue culture techniques. We found a way to inhibit specifically cervical cancer cells, but not the normal cervical cells. And I was mentioning this earlier. We discovered that there's an anti-malarial called artemisinin. It's actually been around for like 3,000 years. The Chinese have used it for many years to treat malaria symptoms. And that particular compound is extremely toxic to cervical cancer cells. And so you might question, well, why do you want to do that if there's a vaccine that's going to prevent cervical cancer? Well, one of the things that Sherry's going to talk about is that it's nice if you can do the science and you show it works, but then to get it to work in the population is a whole different story. But the other thing is that in developing countries, the NIH has made some, and Mark Schiffner's group has suggested that vaccines may not be the way to go in developing countries. It may be a rapid, cheap diagnostic followed by a rapid self-administered treatment. And so we're taking that treatment because artemisinin is used worldwide to treat malaria, and we know it's relatively non-toxic. And so we're using that compound in a clinical trial right now at Johns Hopkins, working with the OBGYN group up there, Connie Trimble. And what we're doing is we're making suppositories, vaginal suppositories that contain the anti-malarial. And what she's going to evaluate is when patients come in, if they have a moderate degree of dysplasia, but not cancer, that takes a long time to progress to cancer. And so there's a 4-week period. If they detect something that they might want to excise, there's about a 4-week period before they come back for that operation. During that 4 weeks, Connie's going to administer these capsules of anti-malarial and ask, is there a reduction or a disappearance of the dysplasia with the anti-malarial? We know that these drugs work in tissue culture very well, but we need to figure out if they work in the patient. So it's a very cheap drug, and we're working with an investigator at Ohio State who's developed a very rapid diagnostic. Essentially, it's a swab that you take and send it to a central laboratory, and if it comes back HPV, then the thought is we would send them back some of these suppositories to self-administer. So that's what we're trying to pursue right now, to see if that's a viable way to go. And first of all, to see if it even works on cervical dysplasia. At the same time, we're working with Ireland, essentially, a group in Ireland, a pharmacy group, to make cervical rings. The same, my daughter uses these for essentially birth control. They're slow-release cervical rings, but we wouldn't be applying contraceptive material there. We would be applying the anti-malarial and designing that to release over about a 3 to 4 week period and see if that would have similar activities. It's got the advantage that it would be a one-step application. The patient wouldn't have to administer these suppositories every day and then have to put a tampon to keep it in place. So it would be much simpler and probably more patient compliance than the other system, right? So anyway, so we're thinking down the line, that's the way we're going to be going. And which we're hoping we can get the Gates Foundation interested, because they just came out with another advertisement, essentially, for trying to get people to look at multiple applications of drugs to treat sexually transmitted diseases all at the same time. So one of the approaches would be that we could actually have anti-HIVs at the same time we have anti-HPVs in the same sort of cervical ring. So, so these are very different approaches, but until we see what the clinical outcomes are, but we're really excited about it because we know it works in the tissue culture system, and if it works in the patients, it's a very cheap drug and would be readily administered. You had a question?
In a best case scenario, would this take the place of a LEAP procedure for
Yep,
women who have cervical
exactly.
dystonia? So you would roll this out not just in developing countries.
It would be here.
Yeah.
Right. Because the OBGYNs will tell you the same thing. LEAP sounds like a relatively innocuous procedure.
It's misery.
That's right. It is.
I have 2 daughters, that's how I know. So.
I see. Yeah, so it's not a good procedure, and there are complications, and you could potentially have fertility issues that arise from that. So if we could actually treat without having, because that 4 week gap was before the LEAP would be done, right? So so we should be able to, in a month's period, know whether there's any effect on it. If we're able to clear it during that period, then yeah, we would go on to trials here as soon as possible.
But not to take the place of a vaccine. This is to treat only.
This is to treat
Right.
only,
And
right?
is there resistance to the vaccine in like Liberia, developing countries where cervical cancer rates are high, or?
There isn't any resistance. It's just the vaccine we have in this country covers right now just 2 types that are related to cervical cancer, 16 and 18. The new one that Merck is coming out will cover 7 highly malignant ones and 2 benign ones. So that'll be more broad coverage. But the reason that we were thinking about developing countries first is to get people to come back 3 times
Right.
For an expensive vaccine. Probably not going to be very effective. And I don't know if Sherry will mention this, but there are advances that we may not need 3 vaccinations to get good coverage on that. But anyway, that's just to give you another idea of things that we're doing for cervical cancer. Yeah.
Are you looking at the synthetic version of artemisinin as well?
Right now we're using a DHA, which is a metabolite of artemisinin. And artesunate. Artesunate is one that's approved for a treatment. And that'll be probably our first round. That's the one that's being done at Hopkins, is artesunate. Strangely enough, the parent compound, even though it works in a patient, doesn't work in tissue culture. And that's because in the patient, you swallow that, but then it gets metabolized in the liver, and it goes on to these other compounds that we're using. So we don't get that effect. We don't have a liver in the culture. So we're going with the metabolites that are biologically active.